How will the internal medicine curriculum look like? What's the kind of overall structure? And I think one question that trainees have is, how will it differ from what is already here at the moment?
We are trying to do a separate piece of work at the same time, and that is that the General Medical Council have widely consulted and approved what they're calling their generic professional capabilities. They wish all curricula in all specialties, not just physicianly ones, to emphasise the whole of a doctor's professional practice, and to ensure that curricula in the future are structured around all the areas of professional work that you need to do in order to become an effective consultant or general practitioner. But the second thing that they are doing, and which we support enormously, is to move towards an outcome-based curricula, trying to simplify the competency-based approach that we've had now. So what we've tried to do is to take the changes that we need for shape of training, with the changes that we need for the curricula about generic professional capabilities, and then thirdly, at the same time, we want to simplify the assessment process, and in particular to get away of this feeling that you have to tick off 120 boxes. So I think that the first thing to say is that this is a complex change. All these three things may have been needed, but we want to do them together rather than doing one and doing another and doing another. So I think that's the first point. The second is that we wanted to have to emphasise particular areas. We wanted to emphasise outpatient work. It has rather lost its focus with core medical training. So with our approach on quality criteria, we have tried to up the importance of that, but many doctors will spend most of their life in outpatients, one way or another. So learning the skills of outpatient medicine and of following patients through and of chronic disease management are a really important part of the new curricula. Secondly, we want to make certain that they are expert in acute medicine and in providing a safe service. So we're emphasising that and the areas of inpatient care in the first year. Thirdly, we are lengthening this early or basic stage one of internal medicine by trying to improve the transition from what would now be seen as core medicine, or perhaps in old terminology SHO training, into registrar.
CMTs, we know, have a lot of difficulty between the service provision and training conflict, perhaps more than some other specialties. How do you think these changes, how do you think internal medicine will tackle that? And particularly with the outpatient clinics, will there be a dedicated time? Will there be a set number that they need to do? How will we actually drive a change for the training? You
will certainly need minimum numbers, and the current minimum numbers are too low. So I think that's the first thing to say. The really key point, though, of course, is that we don't have enough doctors for all the opportunities, both service and otherwise, that are currently there. And this is causing huge stress. We are maintaining recruitment numbers, but the actual demand for physicians at every level is clearly very much greater than is currently being provided. With the current immigration laws, I don't see that changing.
What role would JRCTB have in terms of changing that ethos that's there at an NHS trust level to try and drive these changes?
We've started off trying to use our ability to influence the environment. At the end of the day, PTB's role is to set the curricula. And the curricula are actually delivered by the deaneries in Wales, Scotland and Northern Ireland, and by the LETBs in England. So it is the postgraduate deans and for physicians, the heads of School of Medicine, whose job it is to actually deliver the curricula. But we are trying very hard to work collaboratively with them and with the regulator, the General Medical Council, in order to give them the tools to be able to influence the service. So that is why, with the support of your committee and the other trainee committees, we did a lot of work producing the current quality criteria for core medical trainees, which actually starts to set the standards that heads of school and training program directors can start to hold trust to. Now, it is easier to use that when you're either adding posts or removing posts, because you can now set standards. But when you are able to present the data, when you're able to show there are differences, then that is also a tool for change. You will also know that we're just starting a project to specifically try and support the medical registrar, using the same sort of approach of setting quality criteria that are measurable and therefore hopefully will lead to change. But you're right, there is always a tension between service and education, and as I mentioned earlier, it is made worse at the minute because of the gaps in the workforce and doing jobs that often are not needed to be done by the grade of doctor that's having to do them at the moment.